From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, I'm Dr. Kristin Walter, Deputy Editor at JAMA. I'm joined today by Dr. Jennifer Flythe, Professor and Chief of Nephrology at the University of North Carolina School of Medicine and Director of Dialysis Services at the UNC Hospitals in Chapel Hill, North Carolina. Today, we will be discussing a JAMA review article titled Dialysis for Chronic Kidney Failure that was published online on October 2nd and was co-authored by Dr. Flythe with Dr. Suzanne Watnick. Welcome, Jenny.
Thank you for having me.
Can you start by defining kidney failure and describing how it can be treated?
Kidney failure is typically defined as a glomerular filtration rate less than 15 mils per minute per 1.73 meters squared. It can be treated with kidney transplant, hemodialysis, peritoneal dialysis, or supportive care.
And what are some common signs and symptoms of uremia in patients with chronic kidney failure?
Uremia often presents with nausea, poor appetite, sometimes a metallic taste, fatigue or pruritus, and in severe cases, we might see seizures and coma.
And when clinicians and patients are making decisions about when to start dialysis, is there a specific estimated glomerular filtration rate, or eGFR, that should trigger dialysis? And if not, what are the factors that are involved in this decision-making process?
There is no recommended estimated glomerular filtration rate threshold for the initiation of dialysis. Persistent signs and symptoms of uremia and volume overload, such as nausea, fatigue, dyspnea, edema, that are refractory to medical therapies, and then lab trajectories like a worsening eGFR, as well as other lab abnormalities such as metabolic acidosis and hyperkalemia, may inform the timing of dialysis initiation. But ultimately, it's a decision made between the clinician and the patient.
And is there any evidence that starting dialysis earlier is beneficial?
So far, there is no clear evidence that starting dialysis earlier is beneficial. In fact, there was one randomized controlled trial that asked that very question, comparing patients who started dialysis early with an estimated glomerular filtration rate between 10 and 14 to those starting later with an estimated glomerular filtration rate of 5 to 7. And in that study, they found no difference in mortality after a median follow-up time of about 3.6 years.
Interesting. And your article also discusses maintenance hemodialysis and peritoneal dialysis for chronic kidney failure. Can you describe what % of U.S. patients treated with dialysis receive hemodialysis versus peritoneal dialysis?
So in the United States, when patients start dialysis, about 86% receive end-center hemodialysis and about 13% receive peritoneal dialysis, whereas a small percentage, on the order of 1%, start with home hemodialysis.
Are there survival differences based upon the use of hemodialysis versus peritoneal dialysis?
No, there do not appear to be clear survival differences between the two types of therapy, particularly when you look 3 to 5 years after starting dialysis.
And just to discuss hemodialysis alone, can you provide a brief overview about how standard hemodialysis works and how this differs from ultrafiltration?
With hemodialysis, concentration gradients cause solutes, like urea or small uremic toxins, to diffuse from the blood to the dialysate, which is also known as the dialysis solution, and bicarbonate from the dialysate to the blood. So with regular hemodialysis, you are balancing electrolyte concentrations and removing toxins from the blood. Ultrafiltration is another word for fluid removal. Ultrafiltration can be performed at the same time that we're doing hemodialysis and balancing the electrolytes and removing toxins, or it can be performed on its own such that we are only removing fluid.
And hemodialysis can be performed in a dialysis clinic or at home. Can you describe the typical frequency and duration of clinic-delivered hemodialysis sessions versus hemodialysis that is performed at home?
In the United States, clinic-based hemodialysis, otherwise known as in-center hemodialysis, is the most common form of hemodialysis administered. It is typically administered 3 times a week for approximately 4 hours per treatment. However, at some clinics, patients are offered shorter or more frequent or even longer overnight treatments in a clinic, although that's less common. For home hemodialysis, again in the United States, it typically consists of short daily treatments, usually 2 to 3 hours of therapy 4 to 6 days a week. But it can also be prescribed as longer treatments on the order of 5 to 7 hours, 3 to 6 days per week. And when that occurs, it's often performed at night.
And moving on to peritoneal dialysis, how is this performed? And what is the difference between continuous ambulatory peritoneal dialysis and automated peritoneal dialysis?
With peritoneal dialysis, typically a glucose-based dialysis solution is instilled in the patient's abdomen. Then transperitoneal membrane diffusive and osmotic forces facilitate toxin removal, fluid removal, otherwise known as ultrafiltration, as well as electrolyte homeostasis. The degree of the solute exchange depends on the gradient magnitudes, as well as the quality of the peritoneal membrane and the amount of the peritoneal membrane in contact with the dialysate. Typically, in the United States, patients perform peritoneal dialysis at home using machine automated exchanges, and that's called automated peritoneal dialysis, otherwise known as APD. In contrast, other patients may not use a machine and instead use gravity to instill and drain fluid, and that is called continuous ambulatory peritoneal dialysis, otherwise known as CAPD.
When patients are deciding between initiating hemodialysis or peritoneal dialysis, which factors are typically considered, and what are the advantages of each of the dialysis modalities?
So similar to the decision to start dialysis, the choice of modality is very much a shared decision-making process between clinicians, patients, and their caregivers. Things that factor into this decision may include patient preferences and goals, the therapy availability, as well as clinical and socioeconomic factors and cost. Oftentimes, lifestyle considerations influence modality selection. When patients do dialysis at home, either with peritoneal dialysis or home hemodialysis, they have more flexible dialysis treatment schedules, and it doesn't involve having to travel to a dialysis clinic. On the other hand, it does require having a lot of home equipment and supplies. For in-center hemodialysis, patients have to travel to a clinic multiple times per week at a very set time, so have very little flexibility in their schedules, but they're receiving their hemodialysis in a controlled and monitored environment. And patients weigh the pros and cons of those approaches differently, which is why it's so important that shared decision-making really be the foundation of selecting a modality.
And in terms of dialysis access, for hemodialysis, the options are an arterial venous fistula, AV fistula, or an AV graft, or a tunneled central venous catheter. Which of these options are associated with the highest risk of infection, and how common are these infections?
So hemodialysis catheters are associated with infections to a much greater degree than arteriovenous fistulas or grafts. In some cohort studies, it's been suggested that approximately 50% of patients will have an infection of their hemodialysis catheter within 6 months of catheter placement.
And peritoneal dialysis is also associated with infection. Can you describe peritonitis in patients treated with peritoneal dialysis? How does it typically present, and how common is it?
Peritonitis is the most common infection that affects people who are receiving peritoneal dialysis. One study suggested that approximately 28% of patients experience peritonitis in their first year of therapy. It typically presents with abdominal pain and a cloudy effluent fluid, and it's diagnosed with a peritoneal fluid cell count differential and culture.
Your article also discusses non-infectious causes of hemodialysis, such as muscle cramps, headache, hemorrhage, allergic reactions. How common are these complications? And can you also discuss volume-related complications of hemodialysis?
Muscle cramps are reported on average in approximately 53% of hemodialysis sessions, and headache in close to 30% of sessions. Complications like hemorrhage and allergic reactions are much less common, on the order for hemorrhage of 14 to 91 episodes per million dialysis treatments, and for allergic reactions, 21 to 170 per million treatments. Volume-related complications with hemodialysis are very common. We see both hypotension, so low blood pressure during dialysis, which is associated with higher rates of mortality, as well as hypertension, which affects up to 80% of patients receiving hemodialysis, and likely peritoneal dialysis as well, although the data is not quite as strong.
And patients treated with peritoneal dialysis are less likely to have hemodynamic instability than those treated with hemodialysis. Can you describe the incidence of hypertension in patients treated with peritoneal dialysis? And what should clinicians know about the risk of hyperglycemia in patients with diabetes who undergo peritoneal dialysis?
While patients receiving peritoneal dialysis tend to have a more stable blood pressure during treatment, meaning they're less likely to have hypotension during treatment, they do have a high rate of hypertension, and many experts estimate it to be as high as 80% of patients receiving peritoneal dialysis are affected by hypertension. So really not that different of a prevalence as what we see in the hemodialysis population. Patients receiving peritoneal dialysis are uniquely at risk for hyperglycemia because of the glucose-based peritoneal dialysis solution that is instilled in their abdomen. This mandates that we do close glycemic monitoring of patients who have diabetes and who are receiving peritoneal dialysis. And in some cases, it requires that we actually change the fluid that patients are instilling in their abdomen because too much of that glucose is being absorbed.
Your article also discusses conditions associated with dialysis-dependent kidney failure, such as anemia. Can you discuss how common anemia is in these patients, and when should IV iron and/or an erythropoietin-stimulating agent be initiated?
More than 85% of the patients in the United States who are receiving dialysis require treatment for anemia. So anemia is very common. Most guideline bodies recommend that we start therapy for anemia, specifically an erythropoietin-stimulating agent, if the hemoglobin is less than 10, with the goal of maintaining the hemoglobin in the range of 10 to 11.5 grams per deciliter. We typically start intravenous iron if the TSAT, transferrin saturation, is less than 20 to 30%.
For patients treated with dialysis often have changes in bone turnover, mineralization, and bone volume that increases their risk of hip fracture compared to the general population. Can you describe dietary and pharmacologic strategies to manage this problem?
There are several such strategies. Dietary phosphorus restriction is one of the important components of management of mineral and bone disorders in people receiving dialysis. When we ask patients to restrict their dietary phosphorus, that includes curtailing intake of dairy products, as well as phosphorus-based preservatives such as phosphoric acid, and phosphorus-containing beverages, particularly colas. In addition, in the United States, more than 90% of patients receiving maintenance dialysis require oral phosphorus binders. Common phosphorus binders are calcium acetate and sevellum carbonate to help lower the phosphorus in addition to the dietary phosphorus restriction that they are on. In general, we try to maintain the intact parathyroid hormone in the range of 2 to 9 times the upper limit of normal. And we do this by using vitamin D analogs such as calcitriol, as well as calcimimetics such as cinacalcet. And we titrate those based on phosphorus, calcium, and PTH levels. In general, we aim to maintain the calcium level in the normal range.
And as you mentioned earlier, hypertension is a very common problem among people receiving dialysis. Can you describe first-line treatment of hypertension in these patients and how much salt restriction should they have?
First, one of the real challenges in managing hypertension among people receiving dialysis is that we have no evidence-based blood pressure targets for people on dialysis. So sometimes it is difficult to set a target blood pressure when we are administering antihypertensives. For the most part, we aim for a home blood pressure target of less than 130 for patients who are under 65 years old and less than 140 millimeters of mercury for individuals who are older than 65. To meet this, the first and most important component of hypertension management, as you mentioned, is dietary salt restriction and ensuring that we are getting patients to a euvolemic status after dialysis, which we do with ultrafiltration. When patients have received adequate fluid removal and their blood pressure is still high, we then do move on to antihypertensive medications. Typically, the first-line agents are beta blockers and renin-angiotensin system blockers. As third-line agents, often calcium channel blockers. And in some patients, we do use aldosterone antagonists. However, patients need to be monitored for hyperkalemia when those medications are used.
And guidelines recommend smoking cessation, control of diabetes, and control of hypertension for cardiovascular risk reduction in patients with dialysis-dependent kidney failure. Can you describe the data about statin medications and implantable cardioverter defibrillators for primary cardiovascular event prevention in these patients?
Unlike in the non-dialysis population, statins and implantable cardioverter defibrillators, also known as ICDs, are not considered effective primary cardiovascular event prevention strategies for patients receiving dialysis. There have been randomized control trials of patients receiving hemodialysis who were randomized to a statin medication versus placebo. And those studies have shown no differences in cardiovascular outcomes and mortality, even when a reduction in LDL cholesterol has been shown. As such, we don't typically recommend to start a statin therapy in the setting of primary cardiovascular event prevention. However, among patients who are already prescribed a statin, general recommendations suggest continuing it. ICDs, similarly, have not been shown to be effective for primary sudden cardiac death prevention, and they are associated with infection and lead malfunction among patients receiving dialysis. However, we do recommend that ICDs are used in the setting of secondary sudden cardiac death prevention.
And common symptoms among people treated with dialysis include pruritus, concentration impairment, muscle cramping, insomnia, fatigue, and depressed mood. Can you discuss some evidence-based treatments for these symptoms, particularly pruritus and depression?
Close to 50% of patients receiving dialysis report pruritus. The first-line therapies tend to be fragrance-free emollients or moisturizers that have a high water content. In some cases, oral antihistamines such as loratadine and topical analgesics. There is a new medication, a selective kappa opioid agonist called difelikeflin, which is a newer but more expensive medication. Recent randomized controlled trials have shown that patients randomized to intravenous difelikeflin versus placebo had greater improvement in their itching. For depression, close to 40% of patients report having a depressed mood. In a recent randomized controlled trial that randomized patients to sertraline versus cognitive behavioral therapy, investigators found that depression scores improved from baseline to 12 weeks in both groups, but improved to a greater degree among patients who received sertraline. On the other hand, patients in the sertraline group did have more episodes of nausea and vomiting and other adverse events.
And can you discuss the prognosis of patients who are treated with dialysis, particularly for their mortality risk within the first 6 months after starting dialysis? And what are the most common causes of death in these patients?
Overall, the 5-year survival rate for patients initiating hemodialysis therapy is about 40%. But as you mentioned, the mortality rate is highest in the first 6 months after dialysis and then drops off precipitously over time. Among patients being treated with hemodialysis, the most common causes of death in the United States are cardiovascular related, second is infection related, and third is dialysis withdrawal. Among patients being treated with peritoneal dialysis, similarly, the most common cause of death is cardiovascular complications. The second is dialysis withdrawal, and infection-related causes is the third most common cause of death.
Can you describe how generalist clinicians can help preserve residual kidney function in patients with chronic kidney disease?
Residual kidney function is often defined as producing at least 1 to 2 cups of urine per day. Ways that clinicians can help patients preserve their residual kidney function is to avoid prescribing nephrotoxic medications such as nonsteroidal anti-inflammatory drugs, as well as avoiding intravenous iodinated contrast media unless it's diagnostically and medically essential.
Thank you so much for sharing your thoughts with us about this interesting and important topic. That was Dr. Jennifer Flythe, and I'm Dr. Kristin Walter. This episode was produced by Daniel Morrow. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.